This is a continuation of your fracture PowerPoints, going and looking, taking a look at fracture complications, and then moving into some of the pediatric differences that you'll see within the child population. So with fracture complications, and keep in mind, I want you guys, part of the assigned reading for this was to use your medical surgical ATI book. They do a really good job of going through and listing the different types of fractures, talking about traction, talking about the complications. So make sure you're reading those outline formats, because I may not touch on everything in there, but it would take me hours and hours to read through that for you. So I put that on you. So we have certain fracture complications that we need to be aware of. The first one is shock. Then we have fat embolism syndrome, compartment syndrome, and venous thrombosis embolism, which is or otherwise termed as a VTE. With shock, what's occurring in shock when someone goes into shock is you have severe vasodilation where everything is being shunted towards the vital organs. Okay, those vital organs, our body senses that they need to be protected. So you'll have patients that end up with low blood pressure, pallor, confusion, decreased urinary output. Okay, so with this, what we have to do, and this is a lot of times with your more severe fractures like pelvic fractures and open femoral fracture. Okay, so our nursing interventions here first is it is an emergency. They have to stabilize the fracture, and then they're going to do things like replacing blood and fluids. Sometimes it's due to blood loss because they have a reduced volume that they go into shock, and they're going to relieve or assist in relieving the pain. Fat embolism syndrome, there's a triad of things that the patient may experience. Hypoxemia, which is a lack of oxygen to the blood, so you may see cyanosis, respiratory distress, may complain of chest discomfort. Okay, they may have a decreased mental acuity. They tachycardic, meaning very fast heart rate. Chest discomfort, I already talked about, and confusion. So this is, you look up at your PowerPoint slide, and it mentions the respiratory distress. They may also have your neurodysfunction, which causes the mental status changes. And later on, they may have a clotting disorder where you see the signs of this are petechiae in the mouth, the conjunctival sacs. You'll actually see bleeding kind of under the skin and in the anterior chest wall. Usually, if it's going to occur, it's going to be within 12 to 72 hours after the fracture has occurred. And occurs typically with your long bone fractures, femoral fractures, pelvic fractures, things like that. And this is what happens here is fat globules are released from the bone marrow, and they enter the circulation combined with platelets. So they kind of block off, could block off areas of the lungs and things. Oxygenation is reduced drastically when someone has a fatty embolism. VTE, deep vein thrombosis. Okay, damage to the vein causes thrombus formation. Whenever that vein, especially from a fracture, it can cause that thrombus formation, and it can block off the circulation down to extremities. Okay, so the thrombus enters the circulation, which leads to vascular insufficiency. And what I mean by that is when it's insufficient, meaning we don't have enough circulating blood and oxygen, so patients will experience pain to that extremity. You'll see a change in their circulation sensation, movement of their toes, and then they could lead to a pulmonary embolism where the blood clot goes into the lungs, which it would manifest with symptoms similar to the fatty embolism. Compartment syndrome, what occurs here is you'll have the compartment is surrounded by fascia, which is a non-elastic tissue, and you'll see patients that will complain of a sudden lots of pain in that area. The patho, I guess, behind it is sudden decrease of circulation to the distal area. They'll have pressure from internal swelling, and so it'll be like the cast is too tight. And so this is where, with our assessment, we have to monitor the P's, pain, pulselessness, pallor, paralysis, and paresthesias. And it's an emergency. Okay, they'll have irreversible limb damage can occur within 6 hours. These are some of the things that can occur with compartment syndrome. Okay, they typically are going to do surgery and do a fasciotomy on these patients to try to relieve the pressure, and this is where they make a surgical incision through the tissues to relieve that pressure. Okay, And again, our job is to be assessing for this and assessing for these potential complications as they occur. Treatment of the emergency complications, again, we need to maintain immobilization of the fracture. If you look in your ATI book, in page 456, it goes through these complications and it talks about the clinical manifestations, the nursing action, and the client education. In this class, these are the key things that we need to be focusing in on. What do we need to do as a nurse to assess, monitor, create a plan of care for these patients? So when we treat these patients emergently, we need to monitor respiratory effort again. What are we trying to watch for? We're trying to see and monitor for those complications, the fatty embolism or the pulmonary embolism if they end up with a clot, a venous clot. Circulatory effort as well, looking at whether they're showing signs of shock, which would be low blood pressure, pallor, tachycardia, which is high fast heart rate. Neurovascular function, CSM. Can they wiggle their toes? Do we have really good capillary refill when we press on the toenails to see that we have good circulation? Are the toes warm? Things like that. And then we need to offer support for the patient and the family as well. Delayed complications that may occur from a fracture are wound infections and osteomyelitis. I have seen patients that have had compound fractures that come in and they end up with an infection in the wound. They have to put them on a wound vac, which is a kind of a suction type of a mechanism that draws out the moisture and allows the wound to heal. I have also seen individuals with osteomyelitis, which is an infection to the bone structures, and they have to be on very powerful antibiotics. And I see a lot of patients with osteomyelitis that lose limbs because of this, because they cannot get the infection under control. Non-union is other complications where the bone does not come together, and several factors occur or cause non-union when the patient is poorly immobilized. They're not maintaining non-weight bearing like the physician asked them to do. Nutrition is key, and we're going to find that out again when we talk about that in a future lecture. And infection, and then malunion is where it's not healing, and when it heals not lined up. It's malaligned. Avascular necrosis is bone death due to loss of circulation to that area, which can occur. And then you also have the heterooptic ossification, which is abnormal bone attachment. Sometimes people have chronic illnesses and things that can cause that to occur. Prevention of complications. We have complications of fractures can lead to chronicity and reduced mobility. Okay. So the biggest thing is we need to prevent injury across the lifespan. And on my next slide, we'll talk about that a little bit more. Secondly, we need to have effective treatment for the onset through tissue healing. And then tertiary is prevent complications and making sure that we have effective rehabilitation for our patients. As far as prevention of fractures, biggest thing is nutrition, eating well, getting enough calcium and vitamin D, getting a balanced diet, because if we don't have good nutrition, we have reduced immune system and reduced healing abilities. Making sure we wear our seat belts, making sure we're getting enough milk, wearing, and you'll see the wrist and the knee protectors. I have a son that loves to ride his skateboard. He goes out with wrist guards, knee pads, a helmet, things like that to try to prevent him from injuring himself. I want to touch a little bit on the etiology in children. Generally, children, if they have bone fractures, it's from a traumatic injury. I was listening to a video earlier that talked about if it happens to be in the legs and things like that, sometimes they'll start looking at parents for child abuse in that respect, because in most cases, and I'm going to show you a picture on the next slide, you'll see where most of the fractures occur in children. At birth, it's due to trauma, injury, or child abuse, as I said before. Injury at this age is usually uncommon. That's why it's important that they investigate further. Common fractures in children, they usually have fractures of the forearm. And if you look at this, you can see why. Riding skateboards, coming down off a bicycle, they put their hands down. So radius, ulna are both bones. And then most frequently, if kids have fractures, they're hospitalized due to fractures of the femur and distal humerus. What's different about kids is they have a growth plate. So if they fracture that growth plate when they're younger, it can cause chronic issues a little bit later on. Their bones are more porous and weaker, so they may have fractures with minor falls and twists compared to those of us. I know my brother, you're going to hear me use stories a lot, threw in a baseball one year from the outfield, twisted his foot and broke his leg all the way up into the growth plate and wore a cast from his feet all the way up to his hip. Green stick fractures are the most common in children. One side's broken, one side is bent, but they do have a ability to heal a lot more quickly than adults do. So this concludes my lecture on fractures. Again, I would suggest you go in and you read the chapters that are suggested. That the ATI book is a lot more abbreviated, and there's just a few pages, I believe, in your pediatric book that I would recommend that you read as well. Thanks, and have a good day.